Hello friends, here I am going to deal with the MUHS question. Why there is need of this question and answer audiovisual? Because when I was in my residency, I usually think that there should be LAQ, that is long answer question and short answer question in my phone. Because as a pediatric resident, we don't get time for proper learning purpose or for proper studies. You have to learn as case manner, or you have to learn while sitting in the ward. You have 5 minutes for the rounds, then you can read this out. Okay, that's why I am starting this lecture series. First of all, what is P1? I am starting this question paper as paper 1, then LAQ 1, then SN1, like that. So P1 L1 means paper 1, LQ 1, and the first from retrospective manner, like 2022. I'll start from 2022 and before. So the first question while dealing with this case is SIRS, which was asked in 2022 LQ 1 SIRS. In that, we don't just deal with SIRS. Along with that, we have to work on shock also, because shock is most important topic. Okay, shock, and then what is septic shock. Okay, so first and foremost important thing, what is shock? The definition of shock. The definition of shock I am taking directly from the Nelson. What Nelson says, shock is an acute process characterized by body's inability to deliver adequate oxygen to meet metabolic demand of a vital organs or tissue. Here we can say it is nothing but inability of the body to deliver adequate O2 to meet metabolic demands of vital organs and tissue. Initially, we think that shock means just hypotension, but it is not correct. Shock is not hypertension. Shock is having phase of hypotension, but it is a late stage. Can't say hypotension means shock. You have to deal with heart rate, then perfusion, lastly hypotension. Okay, so what are the vital organs we need to give blood supply for? That brain, heart, kidney, and liver. These are the vital organs which body attempts to preserve oxygen for these organs. Okay, and at the expense of other organs, for example, skin, gastrointestinal tract, and muscle. So, whenever a patient is in shock, you feel that skin is cold, the GI system not passing stool, or the muscle power is compromised. Okay, so this is the compensatory mechanism of a body for the shock management. Initially, shock is what? Shock is compensatory. Later, it lead to uncompensated shock. So, when shock is compensated, you can start management. But when it progresses to uncompensated state, it requires much more attention. Hmm? The combination of continued presence of initiating trigger and body's exaggerated response and potential harmful neurohumoral, inflammatory, and cellular response will lead to progression of shock. So, what are the combination? Presence of inciting triggers. Inciting trigger means any infection plus body's exaggerated response and potential harmful neurohumoral plus inflammatory, memory, and cellular response will lead to progression of shock. Okay, then we're going to next slide. What are the types of shock? Sorry. What are the types of shock in children? There are 5 types of shock. First one is hypotensive shock. Second is cardiogenic shock. Third one is distributive shock. Fourth one is obstructive shock. Fifth one is septic shock. So we'll deal with hypotensive shock separately. sorry, hypotension, hypovolemic shock. It is nothing but it is the phase where hypovolemia is there, which is due to intrinsic or extrinsic blood loss or plasma loss. What do you mean by blood loss or plasma loss? Blood loss means acute injury, that is RTA, which lead to hemorrhage. And what is plasma loss? In burn patient, there occur plasma loss, and in nephrotic syndrome, what happens? Bacho is looking edematous, but the extracellular fluid will go to third space, and which lead to hypotension or hypovolemia. Or third one is dyselectrolytemia, that is diarrhea and vomiting. So here you can say that the examples of hypovolemic shock. First one is hemorrhages. Second one is burn or nephrotic syndrome. Third one is dyselectrolytemia, means vomiting and diarrhea. Okay, and now the next one. What is the next one? First we have done hypovolemic shock. Next one is cardiogenic shock. What do you mean by cardiogenic shock? Cardiogenic shock. Cardiogenic shock is seen in patients with a congenital heart diseases before or after surgery, including heart transplantation, or those with congenital or acquired cardiomyopathies, including acute myocarditis. So, cardiogenic shock in this myocardial dysfunction produces pump failure means RV and LV failure. Why RV and LV failure occurs? Due to congenital heart diseases, then cardiomyopathies, then followed by ischemia, then fourth arrhythmia. Okay, friends, you can stop the video and write all these things. Okay, it is mandatory to write all these things. We need to write more and more. Okay, so there is cardiogenic shock, and do you know the further management? And again, we can deal with afterward. Third one is what? Distributive shock. The distributive shock is caused by inadequate vasomotor tone, which lead to capillary leak and maldistribution of fluid into the interstitium. Okay, there is what? Distributive shock. I change my pin. Let me. Okay, what is distributive shock? It is nothing but abnormal vasomotor tone from loss of venous and arterial capacitance. Okay, example is what? Anaphylaxis, drug-induced neurological shock, that is loss of sympathetic vascular tone due to brainstem or spinal cord injury. Okay, or brainstem injury. Then we are going towards next shock, that is distributive or obstructive shock. What do you mean by obstructive shock? Okay, let's take another slide. Obstructive shock stems from any lesion that creates a mechanical barrier that impedes adequate cardiac output, which includes pericardial tamponade, tension pneumothorax, pulmonary embolism, and duct-dependent congenital heart lesions. Means there is obstruction. Why I'm telling standard lines? Because you have to write all these things in the question paper, in the answer sheet. So what you should know the standard lines for that. Okay, the lesions that create mechanical barrier, lesions creating mechanical barrier that impedes adequate cardiac output, which includes क्या क्या करता है वो tamponade, tension pneumothorax, pulmonary embolism, and duct dependent congenital heart disease. CHDs. Okay, this is obstructive shock. So what are the examples of obstructive shock? Coarctation of aorta. Then next is HLHS, severe aortic stenosis. Okay, so now last and most important shock is septic shock. So we need much more attention to a septic shock. If you have question on SIRS, you should start with shock. What are the types of shock? And the other four types you need not to write in detail, but you need to write septic shock in detail. Okay, but what you should include SIRS as a part of septic shock. Okay, not just start with SIRS. You may not write 10 pages on SIRS only. Okay, okay, we'll take another pen. This is much more important topic. Some okay. What is septic shock? Septic shock. In German sheep, if neonate dies, usually it dies with septic shock. Okay, so what is septic shock? We need to thorough with the septic shock. Actually, what is septic shock? Septic shock is discussed synonymously with distributive shock, but septic process usually involves more complex interaction of distributive, hypovolemic, and cardiogenic shock. Okay, septic shock is nothing but a complex interaction of distributive shock. Second one is what? Hypovolemic shock, mix shock, and cardiogenic. So what happens in septic shock? There is loss of vasomotor tone is present. Then there is hypovolemia. Why there is hypovolemia? Because the extracellular fluid is lost into the third space or via bleeding, melena, RTS spread like this, and then heart gets fail. That's why anotropy is needed. Okay. So for most important, septic shock is a or septic shock is nothing but complex interaction of distributive shock, hypovolemic shock, and cardiogenic shock. Okay. So shock, it may be bacterial, viral, or fungal success. Okay. So what is SIRS? SIR is nothing but systemic inflammatory response syndrome. There are criteria given by international pediatric consensus, which includes 2 out of 4 criteria should be present in SIRS to called as patient is going into the sepsis. So for this purpose, to know what is sepsis, you should be able to recognize what is SIRS, and after that you can say the patient is having what? Sepsis. So SIRS, the long form of SIRS is what? Systemic inflammatory response syndrome. Systemic inflammatory response syndrome. Okay, and there are four criteria out of which two should be present. In this, first two are mandatory with other two. So if you say the my patient is having only raise in heart rate, and the fourth one is my patient is having increased RR, so patient is in SIRS, it is not correct. So you need to have this first one criteria or second criteria along with third and fourth criteria. Means, for example, 1 and 3 is present, then patient is in SIRS. For example, 2 and 3 present, so patient could be in SIRS. If patient is having 1 and 2, so patient is in SIRS, but not possible 3 and 4. 3 and 4 should be present along with 1 and 2, or you can say that all these four criteria are fulfilling. So the first criteria is what? Abnormal core body temperature, which is more than 101.3 degree Fahrenheit or 38.5 degree centigrade of the core body temperature, or hypothermia, that is less than 36 degrees centigrade or 96.8 degree Fahrenheit. So patient may be both hypothermic or hyperthermic. Okay, this is very important. Or so there could be a cold shock or warm shock. Okay, second criteria is abnormal leukocyte count, which is either increased or decreased. This much is also important. Decrease. And here is catch: it should the patient should not be on chemotherapy. If patient is on chemotherapy and is having thrombocytopenia, then you can't take this criteria as sepsis criteria. Okay, or 10% of immature neutrophils, means patient is having hypo or hyper, or 10% immature neutrophils, so patient is having abnormal leukocyte count. Okay, according to age you have to take leukocyte count. And third one is abnormal heart rate. Tachycardia with mean heart rate more than 2 standard plus 2 standard deviation is called as what? Tachycardia. And obviously the mean heart rate is according to age of the patient. And the time period is important, which is half to 4 hours. Means tachycardia should persist for half an hour to 4 hours. Not like that you irritate patient and you are saying patient is having tachycardia for 5 minutes and I'm taken this criteria. No, not like that. Patient is having tachycardia which is persistent for half an hour to 4 hours, or in children less than 1 hour, persistent bradycardia over half an hour. Okay, and the fourth criteria is abnormal RR, respiratory rate, which is more than plus 2 standard deviation above the normal for the age, or acute need of mechanical ventilation not related to neuromuscular diseases like GBS or general anesthesia. Okay, so you can revise 1, 2, 3, and 4 criteria. First criteria is what? Abnormal core body temperature, which is more than 38.5 degree centigrade or 101.3 degree Fahrenheit, or hypothermia less than 36 degree centigrade or more or less than 96 point how much 3 degree Fahrenheit. Second is abnormal leukocyte count, which is which is increased or decreased, but the condition is patient is not on chemo. Okay, and more than 10% of immature leukocyte. Third one is abnormal heart rate, means tachy or brady. Tachy रहेगा तो it should last for half an hour to 4 hours, and brady it should be last for half an hour below 1 year of child. And fourth one is here given only abnormal RR. So this is SIRS. So what is sepsis then? Sepsis is nothing but SIRS plus a suspected or a proven infection. This is most important part. Suspected infection. If CRP is positive, ESR increased, you can say this is suspected infection. Okay, so this is sepsis. And what do we mean by severe sepsis? Severe sepsis is nothing but a sepsis plus two or more organ dysfunction. Okay, if the patient is having RS failure, you can include as organ dysfunction. If patient is having oliguria, which is less than 0.5, you can consider as renal dysfunction. If two of them are included, then you can say severe patient is having severe sepsis. If patient is having CNS dysfunction, if patient is getting convulsion, if patient is having RT aspirate or DIC, increased PTDINR, you can say patient is having severe sepsis or patient is having raised hepatic marker. That time you can say that patient is having severe sepsis. Or next one is if patient is having serious dysfunction. Let me change my pen for that. If patient is having serious dysfunction, serious dysfunction. For example, patient is having number one hypertension less than third centile or SBP less than -2 standard deviation. Okay, or patient required vasoactive drug. Here the point is to be taken that if patient is having sepsis, in that patient is having hypotension or patient required vasoactive agent, then you can say patient is having severe sepsis or two of following. In that, unexplained metabolic acidosis with base axis less than 5, sorry, more than -5 milliequivalent per liter. So base axis is more than -5 milliequivalent per liter. If arterial lactate is more than 2 of normal value, if urea present is less than 0.5 ml per kg per hour, or prolonged CRT, which is more than 5 seconds, and core to peripheral temperature gap. Core to peripheral temperature gap is more than 3 degrees centigrade. Out of all this, 1, 2, 3, 4, 5, 1, 2, 3, 4, and this one is 5. Then out of this 5, if any of 2 is present, then you can call it as severe sepsis. Okay, so you should write in notes, on patient notes. The patient is having sepsis along with severe dysfunction, you can write it as severe sepsis. Or patient is having metabolic acidosis, patient is having lactate level more than normal, more than twice of normal. If patient is having oliguria, if patient is having prolonged CRD more than 5 seconds, if patient having difference in core body temperature, which is gap 3 degrees centigrade or more. Or the second one is all included into what? Severe dysfunction. And the next is ARDS. The patient is having sepsis plus ARDS, label it as severe sepsis. Okay, what do you mean by severe sepsis then? Okay, what is severe sepsis then? You know very well, Abhi. So what is septic shock? You guys are a little bit confusing, no? What is sepsis? What is severe sepsis? What is septic shock? Sepsis is nothing but what? SIRS plus suspected or proven infection. Okay, if patient is having SIRS, and you suspect infection. It is what? Septic shock. And what is severe sepsis? Patient is having, sorry, the patient is having sepsis and with serious dysfunction. In that, hypotension is present, or two of these following: metabolic acidosis. Second one is what? Lactate level is on higher side, more than twice of the normal. Oliguria, prolonged CRT, and more core temperature. The difference between core temperature is more than 3 degrees centigrade, or either patient is having ARDS. This is called as severe sepsis. What is septic shock? Septic shock is nothing but sepsis plus severe dysfunction, as a defined, previously defined. Sepsis plus severe dysfunction is what? Septic shock. So shock include hypotension. Second one is metabolic acidosis. Third one is increased lactate level. Fourth one is oliguria. Fifth one is CRT. Sixth one is core temperature more than 6. If first one is present, then you can say patient is in septic shock. And out of these last five, two of them are present. If patient is having sepsis along with increased metabolic acidosis and lactate level increase, you can say it has severe dysfunction and patient is in septic shock. If patient is having sepsis plus oliguria or CRT more than 5 seconds, you can say it has severe dysfunction. Okay, okay, okay. The next next stop is what is MODS? MODS is nothing but multiple organ dysfunction syndrome. So, the presence of altered organ dysfunction such that homeostasis cannot be maintained without medical intervention, meaning more than two organs are getting affected such that the homeostasis cannot be maintained without medical intervention is called as MODS. So it may be hepatic injury. Previously, we have seen that hepatic injury, RS injury, CVS compromise, then renal compromise, two or more of that included into the MODS. Next one is stages of shock. This is topic, stages of shock. Let me decrease my size, pen size. What do you mean by shock? You already know. What are the stages of shock? There are three stages of shock. What are those? First one is compensated shock. Second one is uncompensated. And third one, irreversible. Okay. First, in compensated shock, patient is agitated, irritated, or confused. In compensated shock, he is drowsy. And third, it is unresponsive. Okay, when patient is drowsy and coming to your casualty, the patient is in uncompensated shock. If your writing patient is irritated, then it could be a compensated shock. And next parameter is heart rate. So initially patient is having tachycardia. It is most consistent sign of a shock, tachycardia. Then what happens? There occurs marked tachycardia. The patient is having heart rate more than 200, heart rate more than 180. It is marked tachycardia. And patient may have bradycardia. So in notes you write patient went into the bradycardia, that required CPR, means it is irreversible stage. Okay. Then third one is what? Respiration. Patient is having normal respiration or mild tachypnea. And then patient may have tachypnea, for the sure. If you are having tachycardia plus tachypnea, patient is in uncompensated state. And if patient is in apnea other than unit, you can say patient is in irreversible shock. Never say like patient was in apnea and patient pulses were very good. It's not like that. Okay. Second one is no. The fourth one. This is one, two, three, and we'll take next color. Fourth, which says CRT. CRT. What do you mean by CRT? Capillary refilling time. Increase CRT, then obviously there is increased CRT, but cold peripheral skin with increased CRT. Cold peripheral skin means body is not compensating. Okay, and fourth one is irreversible means obviously there is increased CRT, cold extremity, cyanotic, and or motor skin. Okay, this is very important, student. If you are writing mottled skin was present on notes, you should be knowing that the patient is in irreversible shock. Okay, and the last thing is blood pressure, which is coming into the picture at late stage. Normal BP in compensated shock, hypotension in uncompensated shock, and unrecordable. So make a point that if you are writing death notes, the last things which are to be written in death notes are what? Reversible shock, reversible, patient is unresponsive, patient went into the bradycardia, apnea is present, or if not, then patient is already intubated, CRT more than 5 seconds, cold extremity is present, cyanosis was present, motor skin was present, and patient BP is not recordable. Obviously, you can add pupils in this, and no signs of life were present, so declared as death. Okay, so now what is the management? For the management purpose, you need to write more. That's what we'll do. We'll directly look to the Nelson. Okay. The Nelson. This is the Nelson. First, the management guidelines. Nelson what uses American College of Critical Care Medicine algorithm. American College of Critical Care Medicine guidelines. This came recently. Okay, these are the older guidelines. I deliberately taken these older guidelines to show you what are the changes in recent and older guidelines, because you student, if I told you the recent guidelines, you can't make difference between older and recent guidelines. That's why I have taken deliberately the older guidelines, and I'll make changes in the older guidelines so that you can. Now the guidelines. First, you have to know this. What is this? This is time interval: 0 minutes, 5 minutes, 15 minutes, 16 minutes. Okay, after 1 hour, you should be at the position to tell that patient is catecholamine resistant shock. Okay, you can say you must be knowing that this 5 minutes initial management, 15 minutes you have to start one inotrope, and at the end of 16 minutes you have to say that patient is having catecholamine resistant shock. So at the zero time, you should recognize decrease mental status, perfusion, and begin high flow O2, establish IV and IO access. So you should be knowing that what is shock, we already dealt with that, and the perfusion, you know that. So you should diagnose for shock. And initial resuscitation, it should be done within 5 minutes. And start initial management as boluses of 20 ml per kg isotonic saline or COVID up to 60 cc per kg until perfusion improves. मतलब CRT must be less than 5 seconds, or patient is developing rales or rhonchi or hepatomegaly. So first initial bolus of 20 ml per kg you have given, wait for 5 minutes, then repeat dose of 20 ml per kg, then wait for 5 minutes and again 20 ml per kg. You can stop anywhere. If patient is developing hepatomegaly, if patient is developing rales or rhonchi, okay, you can stop anywhere and correct hypoglycemia or hypocalcemia. And if patient requiring polysis, start antibiotics. Okay, if patient has not improved, then you can call it as fluid refractory shock. Okay, the fluid refractory shock is present. So here comes the change, here comes the catch. The starting of dose. Here is begin inotrope, IV or intraosseous axis. Use atropine or ketamine if required for sedation, to obtain central axis or airway if needed. Reverse cold shock by titrating this catch. What are the new guidelines? New guidelines says if you are looking for cold shock, I'll tell you. What do you mean by okay, cold shock? If patient is having cold shock, you need to start epinephrine as first agent, inotropic agent, which should be started in a dose of 0.05 to 3.3 mcg microgram per kg per minute. Not like previous guideline, they used to start dopamine as a first agent. No, this is not like that. You should start adrenaline as a first agent, which it should be in a dose of 0.05 to zero point 0.3 microgram per kg per minute. For what? For cold shock. If if in case adrenaline or epinephrine is not available, then you should start dopamine, which is in the dose of 5 to 9 microgram per kg per minute. Okay, so if you are not able to start in epinephrine, then start dopamine, but it should be below 9 microgram kg per minute. So what happens? The dopamine is having dose dependent management. The dose dependent action. What is this action? The action is renal vasodilation present up to 5 microgram per kg per minute. Okay, up to 5 microgram, the dose is renal dose, and 5 to 9 microgram patient, sorry, the dopamine is having cardiogenic action, and above 10 or equal to 10 microgram per kg per minute, dopamine is having intense vasoconstriction. Okay, so the dose dependent dopamine action you need to taken into consideration. So the next one is when to start in norepinephrine. If patient is having warm shock, then you need to start norepinephrine in a dose of 0.05 microgram per kg per minute, and you can titrate it. If norepinephrine is not available, start dopamine. Start dopamine more than 10 microgram per kg per minute. If what norepinephrine is not available, then only. After that, if you know these changes, okay, it is not there. If patient is having this catecholamine resistant shock, then start hydrocortisone. Okay, the dose is 100 milligram per meter square of the body per dose. If absolute adrenal insufficiency is present, okay, then if patient is also in shock, then you have to do this fancy management, that is monitor CVP in PICU, maintain normal MAP minus CVP means peripheral perfusion pressure, okay, and SCV2O2 means mixed venous O2 concentration, and cardiac index, which should be within 3.3 to 6 liter per minute per meter square. Okay, then patient is having catecholamine resistant shock and patient is still in shock with cold shock with normal blood pressure. So what should be titrated again? Fluid. The first scenario is titrate fluid and epinephrine. Increase epinephrine when blood pressure is normal or heart is having less than 70% of SCVO2. Then start with vasodilator, which is milrinone, and if not improved with milrinone, you can add levacimendone. Okay, milrinone, then levocimendone. Then third one is, if patient is having cold shock with low blood pressure, you can start with norepinephrine if already epinephrine is started, or the patient is having SCVO2 less than 70%, start dobutamine, milrinone, or levacimendone. Or third scenario, warm shock with low blood pressure, titrate fluid and norepinephrine, and if norepinephrine has started but heart is at compromise, you can start vasopressin in this case. Vasopressin, terlipressin, or angiopressin. Generally we use vasopressin. If heart it has compromise, then you can start low dose epinephrine. If norepinephrine has already started, add on epinephrine. Okay, if shock is still not reversed, then rule out and correct pericardial effusion, pneumothorax, intra-abdominal pressure more than 12 mm of mercury, and if shock is not reversed, start refractory shock with ECMO. Okay, ECMO has to be started. Okay, friends. Now this is end of shock management. We'll end this topic today.